All right, the tray we're going to be using is a tray called an emery tray. And I'm going to explain some things to you. You need to take that off, get it articulated. I'm going to explain some things to you that I think, if you really take heed, will help you tremendously in dental school and beyond. Okay? And I can tell you that these are problems that private practice guys have. So it's not just unique to dental school. You know, the impressions are a very difficult part of dentistry. So let's try to make them easier. Now, you saw the cord packing Dr. Tucker did, utilizing 2 thick cords. We love that. And take the cords out and maybe leave a cord in if it's small enough, or take them both out. And if there's no bleeding, you're good to go. Rinse carefully and keep the area dry. If the area is dry, it won't bleed. Okay, so now let's show you how to use these. These are emery trays. They're made out of a special kind of a steel. And what you're going to do is take a little piece of thin paper here that's kind of like filter paper, coffee filter paper, but even thinner. And you're going to slide it through just like this, but don't make any folds. In other words, don't pull it like this. We don't want a fold in this paper. We want this paper to be flat, like that. Then you're going to secure it with wax, and you're going to trim away the excess. So now we've done that, and you can see that this is the tray that you end up having. Okay, so secured with wax, and you can trim this side off. I'll have Dr. Lopez do that for me. And while we're doing that, we're going to go ahead and show you how to purge the cartridges. Always make sure you do that. This is our light body material, and you know, it's the orange stuff. So if I can get a piece of maybe a 2x2 or something like that, that would be helpful. Ultradent, or sorry, Aquacel Ultra XLV material, and we're going to purge this out until it comes out. Wow, somebody took that out all the way. That's interesting. Like that, so that we have an even amount. Now, I want you to see how to load the BFCs. The BFC syringe should be loaded by holding it up against the 2 tubes and very slowly squeezing. And then I want you to stop short. Just stop about 1/4 of an inch away. Stop right there and break it away quickly so that you have even amount. And then when you insert the plungers, there's going to be some room for the material to push up towards the top. Okay? And now we're ready to go. It's nice and even. There should be no bubbles in the middle of these cartridges. Then we can slide this over and click it into place. You have to go to the gym to get trained for how to do that. I mean, that's a tough one. And then this little tip can rotate around. This little tip can rotate. But that cartridge is ready to go. The 2 little bubbles at the top there are not a non-issue, because they're going to get purged right out. But if you have a bubble in the middle, that's a problem. Okay? The other thing you don't want to have is you don't want to have the 2 materials mixing right now. The orange and the gray should not mix. The catalyst and the base should not be mixing at this point. Then we're also going to have the other material, the heavy body, ready to go in the tray. You're going to bleed the tray as well. Bleed it first. That's all we need to do. I see a lot of bleeding out there that looks pretty serious. We don't need to waste anything. All right. And then we're ready to go. You want to go ahead and try the tray in the mouth and make sure the patient can close all the way. One of the things that I found to be very helpful is if your patient has a hard time biting down with the tray in the mouth, put your fingers over here and have them bite down where your fingers are, and they'll find their maximum intercuspal position. The idea is to find the MIP position, and so that's that. Another thing that's very interesting is I see people do this. They inject the material in the mouth, and then they put the heavy body in, and they go, okay, bite. Crunch, right into the tray. So they're hovering the tray above the area, or they're just lightly setting it on the teeth and having the patient bite down into it. I don't want you to do that. I want you to seat the tray. I want you to seat the tray, then have the patient bite. When you seat the tray, then you can, at that point, let go of your retraction of the tongue and let the tongue go up against the tray. Oftentimes you end up getting a distortion and whatever because the tray is not seated before the tongue gets over to the teeth. Okay? Great. So now we're ready to go. And like Dr. Tucker showed so nicely in the video, I really like the way he did that, is that he was inserting the material into the box first and going back and forth and really getting all the details. And then he said, if you remember carefully, injecting into the line angles. So not letting the material flow from above like this, but getting your tip into the line angles and all around your inlay. Now, a lot of people would say, okay, it's time to put the heavy body on. Wrong. You need to cover every square millimeter of tooth structure. Everything. Everything. The whole tooth. Buccal, lingual, mesial, distal, facial, occlusal, everything. I want that entire tooth 100% covered. Okay? The other thing that you're going to want to do is put a little...
There you go.
Okay, put a little bit over the occlusals, and another thing that some people dig that could be helpful to avoid inaccuracies in the bite is while you're at it, go ahead and put it down the central grooves of the opposing. How cool is that? So there are no bubbles. Hello. And then in comes the tray, and watch the move. We're retracting the tongue. We come in, we seat the tray, remove the mirror from the tongue, let the tongue come over, then they bite down. You see that move there? You are going to save yourself so much grief if you got that figured out early enough. And then have the patient bite down completely, and they're going, I don't know where to bite, I don't know where to bite. And then you can put your finger here, and they'll bite in the right position. Somehow, pushing on the side that's not numb gives that patient a little appropriate reception, and they kind of know spatially, oh, I know what to do. And their jaw will come into MIP. It's very interesting. So we want to hold this for, have the patient bite down, and you're holding the chin the whole time. And this is a good time to talk to your patient. So I just want to let you know, I really think today's procedure went great. We were able to save a lot of tooth structure. And just let you know, we're going to be making a temporary as soon as this impression is done. And the temporary is going to be made with a material that is pretty strong smelling, but it's really good. It covers the enamel, it protects your tooth, and but unfortunately, you will not be able to floss when you have this temporary in place. It's going to, unfortunately, will not let you floss, but it's okay. It's only during the temporary phase, and in 3 weeks or so, I'll have you back, and we'll be able to take that temporary out. The advantage of this particular temporary is it doesn't let your upper tooth drop down into the hole that we've made. It doesn't let your tooth drift, so everything should fit really nicely. And I want you to be careful because things will stick to it. You'll find that gum or bread or anything that can become kind of doughy and sticky can grab hold of it and kind of want to pull it out. So I want you to be really careful. After a few days, you may notice it kind of feels kind of rough and porous. That's normal. Don't worry about it. I know it can be a little bit irritating to you, but it's not going to hurt you one bit. And that's just the way these temporaries are. They're not very sophisticated, but they're very practical. And they're going to take care of the job at hand. Okay? So just want to give you a heads up on that. And let you know also that if you are traveling and you expect to be out of town and can't come back to see me, I'm going to write you a little note and give you my card that tells you what kind of temporary this is, and tell the other dentist why we placed it. Okay? So I'm going to say this is a Duraseal temporary for a Tucker inlay, and this is the technique that we followed. If you want more information, go to the Tucker website. And because the last thing you want is some knucklehead doctor giving your patient a hard time about what he thinks is a bad temporary. And this has happened before. I've had a patient go up to Tahoe, and some guy that doesn't know the first thing about Tucker inlays is bad-mouthing a Duraseal temporary. And he has no clue. So, that's the last, you don't want that happening. Then the patient comes back all confused. What's this about, And kind of good to let them know. what's going on. A little patient education. And you know what? You're doing it while you're holding the impression.
They
Okay.
come back with IRM in.
Yeah, they come back with IRM or
Ferment.
someone puts Fermit in there. Why do I hate Fermit?
It's very hard to.
Why does Dr. Stevenson despise Fermit? I'll tell you why. It doesn't protect the margins. It doesn't get thin enough and protect the margins, number one. Number two, it always has to be adjusted after you place it. It swells. Number three, it is hard to remove. You cannot get it out of the hole. It gets so hard to remove, you're picking and picking and picking at it, that sometimes you have to drill it out and you can nick your margins and hurt the enamel. Do not use Fermit, okay? There's no permit for Fermit, okay? All right. I don't want you using it,
You're hilarious.
and don't tell me, well, I use Fermit. Okay, well, in your, in all of your experience, if you've done what? 2 inlays, and it's worked really well for you. Okay, great. But I can tell you I've done it, and I've been really unhappy, and so has everybody that uses Fermit. So, all right. So we've waited the right amount of time, and now we're ready to take it out. And this is the way I do it here. I'm gonna hold the tray with, like I'm holding a chopstick, you know. And then with my fourth finger up here, I'm gonna have the patient open. I'm gonna help them open by pushing up against their teeth. Do you see what's happening here? Watch this. See this finger here? Pushing to, as they open their jaw. So this patient doesn't have any muscles, so. There. So now I've pulled it this way, and then at this point I can remove the tray. And don't yank on this puppy out here and start torquing it off. Come in here and break it loose. I like